What I thought I'd do today with this group is just really go over sort of GI symptoms in DM, and it's a very cursory overview just to get a sense of what areas are involved. Some of the diagnostic tests that are available, not necessary in everybody, but are available out there to better understand the symptoms and the condition. And my approach really to patients and symptoms is really listening, understanding the physiology, and then trying to treat the underlying physiology. And then we'll discuss a little bit about treatment options. And mostly I'll be focusing on general disease-specific therapy, so not specific to DM, but if there have been any studies that have been specific to DM patients, I will definitely be reviewing those. So for muscular dystrophies in general, GI symptoms are very common, present in 30–60% of patients. And oftentimes the symptoms can precede the diagnosis of muscular dystrophy with irritable bowel type symptoms. And IBS is very common in the general population, affecting 15–20% of individuals with symptoms such as abdominal pain, cramping, altered bowel habits. But among muscular dystrophy patients, especially myotonic dystrophy, the GI symptoms in a quarter of patients are felt to be the most disabling of all the symptoms that one experiences. And some of the common GI symptoms on the left side are difficulty swallowing, chewing, coughing while eating. And the clinical conditions associated with this could be oral pharyngeal dysphagia, which is a term I wanted to throw out for, which is difficulty swallowing because of weaknesses in the swallowing muscles. Esophageal dysmotility, so abnormal contractions in the esophagus itself. Acid reflux can give rise to these symptoms. Nausea and vomiting could be due to diseases such as gastroparesis or acid reflux. Abdominal pain can be from gastroparesis, pseudoobstruction, gallstones, sphincter of Oddi dysfunction, which is spasming of the bile duct sphincter. And I'll go into this in much more detail a little bit later. Constipation, diarrhea, which you can see because of bacterial overgrowth or bile salt malabsorption, and fecal incontinence. So starting with dysphagia, which is difficulty swallowing or choking while eating, is actually the most common symptom described in DM patients. There's no correlation between the peripheral muscle weaknesses, so the weaknesses in the arms and legs, and the severity of the esophageal symptoms. And symptoms that one can describe are difficulty swallowing or food getting stuck, feeling things get hung up at the level of the throat. And this could be due to myotonia of the face, jaw, tongue muscles, pharyngeal weakness or weakness of sort of the swallowing mechanism so that food pools in the back of the throat. Narrowing or stricture of the esophagus because of a complication of acid reflux. Or more recently, we're seeing evidence of spasming of the lower esophagus muscles. Aspiration or coughing or pneumonia because of aspiration, and that can be due to pharyngeal muscle weakness. So with swallowing, the food goes down the wrong pipe, and rather going down into the esophagus and stomach, it goes into the lungs. This can be because of a weak upper esophageal sphincter and acid reflux, where contents from the stomach come up into the esophagus and then end up in the lungs, especially at night while sleeping, or chest pain because of acid reflux. Some of the available testing, most commonly you'll see swallow studies or video fluoroscopy. And what the study entails is drinking barium in the presence of a speech therapist, and they watch as the barium is pushed down into the esophagus to see if there's any pooling of the barium in the upper part of the mouth, or if the barium goes into the lungs. So the swallow study is really looking for the oral pharyngeal, the swallowing weaknesses. The esophageal manometry is a little bit more invasive, and that's to test the function of the two sphincters we have. So we have an upper esophageal sphincter, a lower esophageal sphincter. These two sphincters, the reason to have them is to prevent acid reflux, and then the contractions of the esophagus to push the food down. So an esophageal manometry entails placing a tube from your nose into the stomach, and this tube is connected to a computer. When you swallow, you can measure the contractions as you see here. And then with new technology, we get prettier pictures and higher resolution mapping of the esophageal contraction. So this is what normal looks like. And in individuals with DM, you can see weaknesses up here in the pharynx. We can see weaknesses here in the upper esophageal sphincter in this area. And we can also see weaknesses in the lower esophageal sphincter down here, which increases one's risk for acid reflux. So in individuals with dysphagia where you're not difficulty swallowing, chest pain, acid reflux, that you're not responding to therapy, your physician may recommend esophageal manometry to better characterize what's going on. Outside of esophageal motility testing and the videoesophagram, you have endoscopy, which entails a camera that goes into the mouth and looks at the esophagus and stomach, and that's really looking for any complications of acid reflux. This really should be done with caution, as the endoscopy does require sedation and complications of endoscopy, as we all know with the passing of Joan Rivers. You know, we do this commonly, but it does carry the risk, especially with sedation. And anesthesia and sedation in anyone with DM should be done with caution. Esophageal pH testing, that's to look at acid reflux, and what that entails is a catheter that goes from the nose into the esophagus, and you wear this around for 24 hours, and during those 24 hours it can measure how much acid or bile is coming up. And if you're having symptoms of coughing, chest pain, you can actually push the button and we can see if each of those symptoms are associated with an acid reflux event. So you diagnose this problem. What are some of the things that we can do to help treat? For the oropharyngeal dysphagia, the difficulty swallowing, there's speech therapy that can help with strengthening of the muscles. It can help with positioning, so doing a chin tuck, turning one's head can help with swallowing. Dietary changes like chopped diet, soft, thickening of the liquids. And in very severe cases, especially if there's aspiration, pneumonia, weight loss, then one can have a feeding tube. And one of the common ways to place a feeding tube is through endoscopy, where you use the endoscope here to help guide the placement of this catheter, this feeding tube into the stomach. And then in individuals with GERD or acid reflux, dietary changes are important. So avoiding things like acidic foods, spicy foods, fatty, caffeine, alcohol, unfortunately all the good stuff, and remaining upright about 3 hours after eating. So it usually takes 3 to 4 hours to digest food. So if you eat and go to bed, within 1 to 2 hours, you're going to bed with food in your stomach, and if you have a weak lower esophageal sphincter, with gravity, food comes up into the esophagus. Elevate the head of the bed by at least 30 degrees. A medical bed is great. If you don't have a medical bed, one thing you can do is take 6-inch blocks and put it underneath the base of the bed, and that raises the whole bed up. Using a pillow or a wedge can be helpful, but most of us, when we sleep on a pillow or a wedge, by the end of the night, you'd end up sliding down, or it becomes hard on your neck and your back. So if you raise the whole bed up, it's easier on the rest of your body. Acid suppression therapy, they're all essentially the same. And sometimes Reglan or metoclopramide can help, especially if there's slow stomach emptying, and to help with the motility of the stomach. Which gets me to the next topic is gastroparesis, or slow stomach emptying. And DM patients have, in general, slower stomach emptying compared to healthy individuals. And there was a study done in a DM clinic in patients without any GI symptoms, and even in the absence of symptoms, the stomach was slower to digest and likely increasing the risk of reflux. Symptoms can be nausea, vomiting, abdominal pain are the 3 most common symptoms, but you can also get bloating, fullness, feeling excessively satiated after a small meal, and again, worsening of acid reflux. In diagnosing gastroparesis is relatively simple with imaging tests. So the gold standard right now is called a gastric emptying scintigraphy, and essentially what you do is you eat scrambled eggs, bread, with some jam. So it's a standardized meal, and a little bit of technetium is cooked into the eggs. You eat the meal, and then at 1 hour intervals, images are obtained to see how much food remains in the stomach. So this is someone who has normal gastric emptying, so you see over time the stomach empties here, and there's less tracer in the stomach, more in the small intestine. And this is someone with slow stomach emptying, where over time you see very minimal emptying in the stomach and very little in the small intestine here. So so if someone has symptoms of nausea, vomiting, pain, and I'm worried about gastroparesis, this would be the next step. So there's no cure for gastroparesis. The symptoms are really aimed at treating the symptoms. And the first line of treatment are dietary changes. So fatty foods are harder to digest, so you want to eat low-fat foods. Avoid fiber. So what we think of as a healthy diet in gastroparesis is not good. The roughage, so raw fruits, raw vegetables, you want to avoid those and eat small, frequent meals. So instead of eating 3 large meals, take your caloric needs and spread it over 5 smaller meals. Become more of a grazer. Stay hydrated with electrolytes. So drinking water alone is not enough. You need something with electrolytes to help with the hydration. So Gatorade, Pedialyte are some examples. And this is not meant to be memorized. This is a list of sort of what's available for gastroparesis. And sadly, this is a very short list for gastroparesis in general. And I'll just point out the ones that are currently available. Reglan or metoclopramide here is available. These have been taken off the market because of cardiac issues. The cholinergic agonist medications like neostigmine, bethanical, pridostigmine, these are medications that are used in neurology, such as myasthenia gravis, haven't been really well studied in gastroparesis, but because of understanding the physiology of gastroparesis, it has been used with success. Erythromycin and azithromycin, which are antibiotics, can increase emptying, but in general, it does not affect symptoms. And these are things that we've used for non-DM patients, injecting Botox into one of the pylorus, which is a valve in the stomach, which Dr. Day and I have had discussions about the safety of using Botox in someone with muscular dystrophy. Has not been described, has not been done, and I'm not sure if we're ready to be the first ones to do it. A jejunal feeding tube, so it's a feeding tube that is placed beyond the stomach, so you're bypassing the stomach completely. And then electrical stimulation, again, has not been studied or described at all in DM patients, but it looks like a cardiac pacemaker, but it's an electrical stimulation device where we implant that on the stomach, and it has helped with symptoms of nausea and vomiting, but it doesn't really increase motility. So that's a short list. The list in DM is even shorter. The therapies that have been studied in DM are metoclopramide or Reglan, which has been reported in the study included 16 patients, increases gastric emptying, but minimal improvement on symptoms. Erythromycin in 10 patients did not improve gastric emptying or symptoms, but it actually helped with diarrhea. And most likely the reason it helped with diarrhea is that patients with gastroparesis are more likely to have bacterial overgrowth. And bacterial overgrowth is excess bacteria, instead of residing in the colon, resides in the small bowel and can lead to malabsorption. So the erythromycin as an antibiotic will treat the bacterial overgrowth. And cisapride has not been well studied, but has been described to be used in DM, but is no longer available. So that moves me on to intestinal pseudoobstruction, which, if you look at this X-ray here, it's where you see kind of massively dilated, loops of intestine throughout. And what intestinal pseudoobstruction is, or CIP is the other term that we use, is kind of abnormal or disordered motility of the small bowel. It can be because of the nerves or muscles, and in DM, most likely a combination of the both. It leads to obstructive symptoms. So it looks just like a mechanical bowel obstruction where you have dilated bowels, abdomen is distended, abdominal pain, nausea, constipation, fullness, vomiting, all the symptoms that normally we see in patients with scar tissue causing a mechanical bowel obstruction, but there's not a true obstruction there. Thus the term pseudoobstruction. This is more of a motility problem. So when someone presents with an X-ray such as the one I showed earlier, and you're thinking of pseudoobstruction, how do you make the diagnosis? And the most common thing to do is a CT scan. And what you're doing with a CAT scan is you see here the dilated bowel, but what you want to make sure is that there's no transition point is what the radiologists look for. And a transition point is kind of a point where you see all this dilation, and then there's one point where there's a narrowing, and then you get normal bowel. And that area of narrowing is typically scar tissue, tumor, but more commonly scar tissue. In pseudoobstruction, you don't see that transition, so it's sort of dilated everywhere, and you don't see a transition point. So with the diagnosis of pseudoobstruction, you treat that much differently than you would with a mechanical bowel obstruction or scar tissue obstruction. What you want to do is avoid barium studies. So barium is a thick paste that you drink, and you can follow the lining of the esophagus, stomach, small bowel, looking for mechanical obstruction. The problem when the bowel is this dilated is you need to drink a lot of barium. And what happens with barium is if you don't get the barium out, it gets stuck in there, and you get this big, hard, mass of barium that can lead to a bowel obstruction. So as family members, as patients, if you end up in an emergency room in a hospital with symptoms concerning for pseudoobstruction, don't let your doctors do a barium study on you, because the mechanical bowel obstruction, scar tissue, it's much, much more common than pseudoobstruction. So that's usually the first thing people think of is there's got to be scar tissue, there's got to be a blockage somewhere. And in specialty centers, like our center, we can do a little bit more sophisticated testing where we can actually test the motility or the contractions of the small bowel. And it's called small bowel manometry, and we can do endoscopy, and using X-ray, we place a catheter into small bowel, and you can see here our contractions of both, actually up here is of the stomach, of the small bowel, where we can look at the contraction patterns, contraction amplitudes, and we know what normal is, and in pseudoobstruction, you see various patterns of abnormalities. So how do you treat pseudoobstruction? Number one is avoid unnecessary surgery. Whenever ER doctors, surgeons see those CT scans or the X-rays of massively dilated bowel, the first inclination is rush off to surgery. Unless there are what we call alarm features, fevers, severe tenderness, elevated white blood cell count, signs of acidosis, then there's time where you can treat conservatively with nutritional support. So, nutrition by vein, IV hydration, decompression. And if the pseudoobstruction is involving the stomach and small bowel, the decompression is with, a nasogastric tube, so a tube that goes from the nose into the stomach where you can suck out the excessive fluid in the air. If the colon is dilated, a rectal tube, so a tube in the rectum, you can suck out the air from below. And then if there is bacterial overgrowth, which most likely there is, you can treat bacterial overgrowth with antibiotics. And then use motility agents that are available, so either the erythromycin or azithromycin, metoclopramide, octreotide, which is a medication that's used for certain types of hormonal cancers or for individuals with bleeding from liver disease, actually helps with motility of the small bowel and can be given as an injection into the skin, or medications like neostigmine, pyridostigmine. These can all increase motility, and monitoring. So just monitor. So you do the hydration, nutritional support, and if things get better, then you can be more reassured that the diagnosis is pseudoobstruction. If the symptoms worsen as you treat conservatively, then you always have to worry about potentially there is a blockage there. Most individuals with a mechanical blockage have had a history of prior surgery. So having had a prior gallbladder surgery, hysterectomy, appendix surgery. So any abdominal surgery increases your risk of having scar tissue inside the abdomen that can lead to a mechanical bowel obstruction. But if you've never had any type of abdominal surgery, most likely you're dealing with pseudoobstruction and not a mechanical obstruction. Again, the concern with undergoing unnecessary surgery, other than the unnecessary surgery part, has to do with the risk of anesthesia. So because of the hypoventilation, the cardiac, your risk for cardiac arrhythmias, avoiding unnecessary surgery is a key part of this. And then, moving on down the GI tract to constipation. In my field, people say, no one ever dies of constipation, but it's really about quality of life. And when you look at health-related quality of life, in general, it's impaired in DM, but GI risk factors that are associated with this decreased quality of life include constipation and gallstones. And this is, right up there with cardiac risk factors, as well as fainting. Is just as bad as constipation in impairing the quality of life with individuals with DM. So when you talk about constipation, you have to define constipation, because if you poll the whole room here, everybody will define constipation differently. And if you look over here, this is what most doctors think of constipation as, having less than 3 bowel movements per week. And we oftentimes fail to think of these other things as constipation. So you as a patient may come in and say, maybe complaining of straining, but you go every day, or having hard lumpy stools, or a sense of incomplete evacuation. So going but not feeling like you've emptied, or having to manually facilitate defecation. And so there are individuals who will go 6 or 7 times a day, but each time have a small hard pellet. That's constipation. And again, making sure that you and your provider are on the same page. I often use this chart here. These are the different types of stool consistencies one can have, and the normal is the type 3 to 4. So if someone's having type 1 bowel movements, 2 or 3 of these every day, it's still, and straining, that's still considered constipation. But if somebody is having, one type 1 bowel movement every 2 or 3 days, you actually want to treat the stool consistency and firm up the stool rather than giving more laxatives. So when I encounter a patient who's complaining of constipation, I'll ask these types of questions, but also bring up the Bristol stool scale so that we're all on the same page. And visually, it's a lot. There's no question, when you point out this is what your stool looks like, as opposed to, a verbal description. So causes of constipation in DM, there are a couple issues. One is slow transit, so things are moving slow through the colon, and this has to do with sort of the altered smooth muscle, and potentially the presence of autonomic dysfunction, and also decreased mobility. In general, exercise helps with constipation, but if you're less mobile and unable to exercise, that will slow down your colonic motility. And anal sphincter function. So that's inability of the anal sphincter to relax with excessive straining, difficulty with defecation and straining. And this can affect up to 90% of individuals with DM. So some of the diagnostic tests, the usual things like fiber, stool softener doesn't work, there's a test called a Sitz marker test, which is a simple enough test to do. One swallows this capsule here. Inside that capsule has 24 plastic markers. And then 5 days later, you come back and you take a x-ray, and we look to see where those little markers reside. And at the end of 5 days, you would expect that more than 80% of the markers would have emptied from the colon. So in this case, this individual has slow transit because at the end of the 5 days, most of the markers are sitting over here. So this goes along with slow colonic motility. Now, at the end of 5 days, if we find that all the markers are clustered down here in the rectum, then it tells us that this is probably more of kind of a defecatory problem. So all the stool gets down to the rectum, but it's just having a hard time getting out. So in that situation, giving more laxatives doesn't help because it just makes more urgency because it's bringing more stool down to the rectum, but you can't expel. Looking at the anorectal function, you can use an anorectal manometry, which is a catheter that has a balloon at the end of it, and you place this into the rectum, and this is done without sedation because we need cooperation, and we measure the resting pressure. We'll have you squeeze, bear down, cough, test the sensation, and this looks at how the anal rectum is functioning. And studies of anorectal manometry have been done in patients with DM and have found several things. The resting pressure is low to normal in individuals with DM, which the low pressure increases one's risk of fecal incontinence. The weaker squeeze pressure, again, increases the risk of incontinence. When we blow up the balloon in the rectum, there's actually a reflex that allows the sphincter to relax. And in the DM population, you get kind of this increased contraction first, and then the relaxation. And what we also see is pelvic dyssynergia, or anismus is the other name for it, is this uncoordinated contraction of the sphincter. So this is normal. You see the rectal pressure comes up, and this is the sphincter pressure relaxing here. In individuals with pelvic dyssynergia, you bear down, the rectal pressure increases, but the sphincter pressure also goes up. So you can see that evacuating stool would be difficult if the sphincter pressure is higher or just as high as the rectal pressure. And unfortunately, the harder you bear down, the worse it is, because when you bear down harder, you're actually recruiting your gluteal or your butt muscles, and you're increasing this pressure further. So how does one treat constipation? First, there's the non-medical therapy, which is exercise if one can do that. Diet, so increasing the fiber in your diet. And if that can't be done, you can do medical therapy with fiber supplements like Metamucil, Benefiber, Fibercon. They're all essentially the same. Laxatives, stool softeners, agents to increase motility. And again, I'll go into this in more detail. And then surgery in very severe cases where we've done things as taking out the whole colon and connecting it to the rectum, or having an ostomy bag. So, people say take more fiber, and that's just a very generic statement, but there's actually different types of fiber out there. There's soluble and insoluble fiber, and they each have a role. And having, a moderate amount of fiber is good, but don't let anyone tell you to keep eating more fiber, because too much fiber actually leads to excessive bloating and gas. So if you're already suffering from, either pseudoobstruction, gastroparesis, bacterial overgrowth, or just generalized gassiness in general, exceeding 30 grams of fiber per day doesn't increase the motility any further. It just worsens the bloating. So the goal is between 20 and 30 grams of fiber, which includes the supplements as well as diet. So soluble fiber, that attracts water, and think of it as the glue or the gel that kind of keeps the stool and the fluid together. You have to be careful if you have gastroparesis, because it can also slow gastric emptying. Diet-wise, there's very limited soluble fiber in diets. I've listed them here. So dried beans, oats, rice bran, not wheat bran, barley, citrus fruits, apples. I forgot bananas, which are in the soluble fiber for diet. Insoluble fiber is really what all the usual foods we eat for fiber, and that helps to kind of bulk the stool, increases the transit, but if you're having kind of stools that are fluffy and loose and they kind of break apart, what you want to do is more soluble fiber. So dietary-wise, the wheat bran, whole grains, cereal, seeds, fruits, and vegetables. So the medical therapies, like I said, the fiber supplements, the osmotic laxatives. So these are laxatives that draw more fluid into the colon and the stool. So lactulose, magnesium citrate, any magnesium product, and Miralax. The stimulant laxatives actually increase contractions in the colon. So that would be Bisacodyl or Ducalax, Senna, glycerin. Newer kids on the block are the secretory agents. They increase the flow of fluids into the small bowel and colon. That includes lubiprostone or Amitiza, linaclotide or Linzess. These are medications that are currently FDA approved for slow transit constipation as well as irritable bowel syndrome. All these medications help with increasing bowel movements. The one symptom that none of these medications help with up here is the bloating. So fiber, laxatives, they don't help with bloating, but these agents down here, the lubiprostone, linaclotide, has been shown to help decrease the symptom of bloating. Suppositories or enemas are helpful in situations where you have the urge to go but are having problems with rectal evacuation. So the presence of the enema or the suppository actually stimulates the sphincter to relax. Other things you can do for defecatory disorders are biofeedback therapy. So use it through the therapist using either an EMG or that catheter. You can watch the sphincter relaxing, and that can help with teaching you to relax the pelvic floor, relax the anal sphincter. And in very severe cases, we've gone to a colostomy where you're bypassing the sphincter and having a bag. There's a rectocele or rectal prolapse, which is a weakness in the rectal wall, and that can be fixed with surgery. There are the gynecologist usually can find a rectocele on exam in women, or there is an x-ray test called a defecography where they put barium paste into the rectum and you sit on a commode in the x-ray department and an x-ray is taken as you're trying to expel the barium. And in general, the principles of biofeedback are, push with less than 50% of the maximal force. So the harder you strain, you're working against yourself. So use about 50% of the maximal forces. Doing Kegel exercises, that does a couple things in terms of it helps strengthens the weak sphincter muscles, but it helps develop an awareness of the pelvic floor muscles. Often people aren't aware of what the pelvic floor muscles are doing. And when we do the anorectal manometry and you see the sphincter pressure increasing while they're bearing down, most people are completely unaware that that's what's happening. Abdominal exercises, so increasing your abdominal muscles doing sit-ups, crunches, anything that can increase the abdominal muscles allows you to contract the abdominal muscles, increase the pressure there without increasing the sphincter muscle. Time bowel movements after meals or when the urge is present. So try not to defer the urge to defecate. Most of us, especially in the Western world, if you're at the mall, at school, at work, if you have the urge to have a bowel movement, most of us defer it, wait until we get home or get elsewhere, and that often turns off the normal sensations that we have. Leaning forward or getting into a squatting position helps to facilitate body relaxation. And oftentimes if you have one of those adaptive toilet seats that are higher, that allows you to stand up more easily off the toilet, it actually makes pelvic floor relaxation harder, because if you're sitting on the toilet and your legs are dangling, that actually closes the angle of the rectum and anal sphincter. And there's actually a device out there. I'm not promoting it in terms of, I get no royalties from it. It's called a squatty potty. And And essentially what it is, it looks like a step stool, but it has a carve out that wraps around the toilet. And so when you're sitting on the toilet, it brings your knees up as if you're in a squatting position, and that helps relax the pelvic floor. And stop trying after 10 to 15 minutes. So spending 45 minutes on the toilet is not helpful. If anything, it weakens the pelvic floor further. So if you've been trying for 10, 15 minutes and nothing has happened, get up, walk around, do your activities, and then when you feel the urge, try again. So leave your iPhones, iPads, Kindles, Fires, whatever it is that you bring in there, leave them outside the toilet. And then on the opposite spectrum of diarrhea, that can be due to malabsorption from the bacterial overgrowth, which I talked about. And you treat that with antibiotics and probiotics. And the diagnosis of bacterial overgrowth is a quite simple test. It's a breath test. You drink a sugar, and then you breathe into a bag every 20 minutes for 3 hours. And what we're looking for is the bacterial fermentation of these sugars. And if the diagnosis is positive, you want to use antibiotics. Antibiotics kill off the good and the bad, so you want to follow with probiotics to help replenish the good. There's bile salt malabsorption, especially if one has had a cholecystectomy or gallbladder surgery, and that can be treated with cholestyramine to bind the bile. And then there's fecal impaction with what we call overflow diarrhea. So there's so much stool in the rectum and the colon that only liquid stool can come around. And you can diagnose that pretty easily by doing just an x-ray. So if someone's complaining of diarrhea and you do an x-ray and you see that the colon is full of stool, that goes along with more of an overflow diarrhea. Because if you're having diarrhea, you shouldn't have a ton of stool in the colon. And then medications. Oftentimes, a lot of the medications that were prescribed for other conditions, the common side effect is diarrhea. So you want to go through your medication list and see what's necessary and what's not necessary. And then I'm going to end with gallstones, which is present in up to 50% of DM patients, and it really results from gallbladder function or poor gallbladder function, so the gallbladder does not contract well, or the sphincter, which is sort of the valve between the liver and the intestine, that dysfunction can lead to poor emptying. And so with bile stagnating in the gallbladder, it can lead to stone formation, and it causes pain after eating over on the right side. Unfortunately, the main treatments for symptomatic gallstones or complications of gallstones is surgery or cholecystectomy. But in trying to avoid surgery, one of the things that have been looked at is ursodiol or ursodeoxycholic acid. And this hasn't been studied in DM, but in the general population with gallstones, it does help to dissolve small gallstones. So it can decrease the gallstones by about 1 millimeter per month. It does prevent complications of gallstones, but if you have gallstones over 1 centimeter or multiple gallstones, it doesn't seem to be beneficial. So in summary, GI symptoms are common in patients with DM. The symptoms can precede the diagnosis of DM and can present very, very gradually. DM can affect the GI tract from the mouth all the way down to the anus. Treatment options are limited but available. The symptoms can affect the quality of life. Symptomatic treatment can improve symptoms and quality of life. So this is not a cure, but we're really trying to make an impact on quality of life and functioning. And testing is not necessary in everyone, but especially if one is refractory or not responding to medical therapy, targeted testing can help us better understand the physiology and guide therapy. And because of the common nature and sort of the slow onset of symptoms, that I would vote that routine GI questionnaires or assessments should be a part of regular DM care. And I open everything up to questions. Yeah, I mean, like I say, it can be at any time. The GI symptoms tend to not parallel with the neuromuscular symptoms. So you can't say that, you know, the Muscle weakness is mild, so the GI symptoms should be mild also. And it can occur at any time. And like I said earlier, oftentimes the GI symptoms can precede the diagnosis of DM.
Oh, I'm sorry. Is there any benefit to just electrical stim, you know, externally in the perioral area or anything just to improve?
I have to admit, that I don't know of.
Okay.
The oral pharyngeal treatment, that's more sort of in the non-GI world. So sort of from the upper esophageal sphincter on down is where my area of expertise and my concentration has been.
And what probiotic do you recommend? And is there any downsides to chronic Miralax use?
There's no downsides that we know of to chronic Miralax use. The caution with Miralax is, again, a little bit or moderate amount is good, but you don't want to overdo it where the stools are getting loose into that type 6 or 7 stools, because the looser the stools are, the harder it is actually to evacuate. So with the pelvic floor dysfunction, if the stools are too loose, imagine the rectum's trying to push the stool out, and if it's liquid, as the rectum pushes, the stool just kind of sloshes around, which is the visual I give patients. Probiotics that have been studied for bacterial overgrowth, there have been a number of small studies. The Bifidobacterium species have shown the most benefit. Bifidobacterium infantis is the one that has had the most vigorous studies, and it's commercially available as a line.
Okay. And is one last question, is sexual dysfunction also associated with the pelvic floor dyssynergia? I know that's not your field as well, but do you see the two related, painful sex or things like that?
No, we see more of the urinary symptoms. And I didn't see any studies that really correlated with sexual dysfunction, pelvic pain with the pelvic dyssynergia, but they're in non-DM individuals, we do see that correlation. So urinary retention, urinary incontinence. Oftentimes, if you see that, it's likely that the pelvic floor dysfunction is also present. Yeah, in the back.
Thank you. This is just a random question just because of my own diet. Other than the concern with sugar, do you have an opinion about Fiber One products?
Fiber One specific? So
we in my family, we have the cereal, we have the fiber bars. Every once in a while we indulge with the brownies, and I know you need to watch the sugar, but other than that, do you have an opinion on whether I should just be foregoing those altogether and using Metamucil, or?
No, Fiber One products are great in terms of having soluble as well as insoluble fiber. If you look at a bowl of Fiber One, one bowl, half a cup, or one bowl has about 14 grams of fiber, which is a lot to eat at once if you're having problems with gas and bloating. So I usually have people kind of break it up throughout the day to.
Do you have a preference of Fiber One or Metamucil? Would you, without sugar, would you recommend Metamucil instead?
They're all essentially about the same. It's sort of what you tolerate better.
Thank you.
Just right next.
Hi, I have a question regarding facial muscles and chewing. My husband is DM2 with weak facial muscles, and the chomp is really weak and takes a very, very long time to eat. Is speech therapy, did I hear you say that would be an option, or what do you do to really concentrate on that portion of eating?
So speech therapy can help with sort of exercises and strengthening, improving the coordination. So it's just sort of think of it like physical therapy, but instead for the arms and legs, for the jaw muscles.
That was excellent. I just wanted to remind everyone that fiber only works as well as the water that you drink with it, and to remember to stay hydrated, because a lot of times it's hard to swallow. Water might go down the wrong way or make you cough, or you may just not remember to drink enough water, but fiber without water becomes cement-like and won't move forward. So,
yes, I have agreed. Make sure you stay hydrated.
Hi, I have a question about. Well, I should preface by saying she had her colon removed in December because of ulcerative colitis on top of impaction problems. And you mentioned something about tightening the rectal muscles because of really loose rectal muscles. There's like uncontrollable all the time. Is there something recommended for surgery-wise for that, or something that can help that strengthen those rectal muscles?
So Kegel exercises will help strengthen the muscles.
But how do I explain that to her, how to do that?
So the way you do Kegel exercises, first you need to
Yes, sir.
identify the muscles, and how you do that. And you don't want to do this all the time, but when you're sitting on the toilet, to have a bowel movement as the stool is coming out, what you do is you squeeze the sphincter muscle to try to prevent the stool from coming out. And that's the same thing when you're trying to do Kegel exercises for urinary incontinence. When you're urinating or peeing, you try to stop the flow. Once you've identified the muscle, then when you're kind of sitting on the sofa anywhere else, you squeeze the muscle and try to hold it there for 10 seconds. Relax, squeeze, hold for 10 seconds. Do that 10 times, then do it 3 times per day. And the goal is not to squeeze as hard as you can. Think of it as training for a marathon. You want to try to squeeze, but hold it for 10 seconds. So it's better to squeeze and hold than to squeeze super tight and let go after 1 or 2 seconds. So you keep doing that, and once you're comfortable doing 10 seconds, you increase it to 20 seconds. Surgeries for fecal incontinence or the weakness of the sphincter muscle, they're there. They've had kind of variable success rates. So women who've had pelvic floor trauma from birth, where the sphincter is torn, then there's surgeries where you can take the 2 ends of the sphincter and overlap them and strengthen them. But in the absence of that, the surgeries have been quite poor for that. There's a new treatment, a relatively new treatment that came out where they're injecting biopolymer into the sphincter to help kind of bulk up the stools. There have been complications of ulcerations in that area. There is sacral nerve stimulation, where it's a nerve stimulator that's placed into the back that helps stimulate the nerve muscles. But again, that's never been done in a DM patient.
And one last question, something to bulk up just since there's no colon in the small intestine, would the fiber things and the things you mentioned help bulk up in the small? I'm just not sure of the relation
soluble
of-
fiber is to help with the bulking.
Okay, so that would help it bulk in the small intestine to
Yeah.
slow it down. Okay, thank you.
I'll just add one thing with regard to incontinence, stool incontinence, especially in the pediatric population. It has to be viewed as anecdotal, but there are quite a few people that have used Myxillatine with some success. And I don't think we understand exactly what's going on there, but there are definitely people, there might be some in the audience, who had a real success, I mean, just directly related temporally to starting Myxillatine. So it's...
Yeah, so John, most likely the reason for Myxillatine helping with the fecal incontinence is that Myxillatine helps with muscle spasticity, and early on, before the sphincter becomes weak, there is a spastic component, and so if the sphincter is spasming, then what you do is you get an overflow. So you get fecal retention and overflow. In pediatrics, the overflow incontinence is much more common than in adults.
I think we have one more.
One last question?
One more question.
Maybe I missed the boat on disease pathology, but you talk about strengthening through sit-ups or strengthening this muscle, strengthening that muscle. What I understand is that our muscles are strong right now as they'll ever be. They won't get stronger. You'll just get weaker. And that exercise can actually help the disease progress. Do you have any comments on that?
Yeah, I mean, I'll let Dr. Day comment on disease progression and muscle strengthening. In terms of strengthening the sphincter muscle, you were talking about just very gentle exercising. The abdominal muscle strengthening, that's sort of part of our general concept of biofeedback therapy. One thing that you can do that instead of doing the abdominal exercise is actually massage. So if you massage and start from the upper middle abdomen, which is sort of where the transverse colon is, and you push down along the left, come down towards the pubic area, that's where you have the that's where the rectum sits, so you're sort of milking the stool down. So if you relax the pelvic floor by using something like a squatty potty and then massage down, that will help with the kind of abdominal muscle strength. But what I try, the rationale for the increasing the abdominal muscles is that so that you can contract these muscles without contracting the muscles down here.